we all know there are different factors. The most common type we can see here is like toxic or the metabolic like alcohol. Alcohol has been seen as the most common cause in the genes. Like if we will discuss about CFP or genes, so these are some of the mutations in the genes that can also result in different types. And then autoimmune, either it can be primary type or secondary type of the autoimmune pancreatitis. Then we have other type of pancreatitis also like obstructive. There can be some obstruction in the duct, like tumor can be there or a stone can be there. And some of the anatomical problems like is already discussed by Dr. Irfan, pancreas division, like when the dorsal and ventral pancreatic ducts get failed, they can cause obstruction and pancreatitis. Now, what is the common presentation of these patients? The most common presentation that we see in these patients is the chronic abdominal pain. These patients, they get recurrent admissions to the same, and the quality of life is affected because of this pain. Not only pain, now what is the like etopathogenesis behind pain? Why there is pain? There are many theories about this. The most common is there is increase in the intraductal pancreatic pressure. Because of this, patient gets pain. Not only this, with repeated inflammation is what happens. There is like a very loss of perineurium. These nerves they get exposed to different noxious stimuli, and patient gets lot of pain. Then they can also present with other features like when the exocrine function is affected, there can be weight loss and this steatorrhea also. And not only this, they can also present with some complications like cirrhosis, and if there is some obstruction, they can also present with the features of cholangitis and jaundice also. These are some of the common presentations of chronic pancreatitis. How should we diagnose these patients? First of all, the history is very important. And then we can go for the clinical examination. Other than that, we have some modalities also, like starting from the basic X-ray abdomen and then USG, CT, ERCP. ERCP is both diagnostic as well as therapeutic here. Then MRCP we can do, but if like we are suspecting some malignancy or suspicious is there, we can go for endoscopic ultrasound also. For the students, there is a picture. This is X-ray abdomen, which is showing calcifications in a patient who was suffering from the chronic calcific pancreatitis. This is another picture, CCT abdomen. That is showing, if you can see pancreas, there are a lot of calcifications inside the pancreas. Now, how can we manage these patients? This is not only the surgical management part. It is a multidisciplinary approach, I can say. There is role of radiologist, gastroenterologist, and surgeon also. So first of all, we have to eliminate the risk factors. Like suppose if the patient is alcoholic, we have to stop alcohol intake. And then smoking is to be stopped. Then the main important thing is pain management. How can we manage pain? Starting from the basic painkillers like NSAIDs and then tramadol and then other opioids, we can manage pain. But the problem with the opioid intake is that these patients, they develop dependence on these opioids. Other than this, we can go for sometimes celiac ganglion blocks also, and then enzyme supplements are to be given in case of chronic pancreatitis. Then some of the minimal invasive procedures can be done by the interventional gastroenterologist in the form of sphincterotomies, or we can go for stenting of the pancreatic duct, and even endoscopic celiac narrow block can be given. And sometimes ESWL can also be done if the stone is big, like around 5 millimeters. Now, what are the indications for the surgery? There are different indications for the surgery. The most common indication in these patients is the intractable pain. Most common indication. Then, if the patient is having other problems like biliary obstruction is there, duodenal obstruction is there, or the patient is developing this left side portal hypertension because of splenic vein thrombosis and pancreatic ascites, pancreatic fistulas. Now, how can we choose the procedure? Which procedure should be done in which patient? We have different types of the procedures, like we can go for just a draining procedure or a resection type of the procedure, or we can combine both these procedures. This all depends on the anatomy of the pancreatic duct and whether or not the disease is diffusely involved in the pancreas. So suppose if the disease is mainly localized to the duct and the duct is dilated, that time we can just go for the draining procedures. And if you feel that there are some indications for the resection procedures. For example, if the patient is suffering from small duct disease, that time it's better to go for resection. Or if the patient is not responding to our previous drainage procedures, or we have suspicious of malignancy, then definitely we should go for the resection procedures. These are some different procedures you all might be knowing about this. Like initially, dual pancreatic cholecystectomy was done, not this time. We do modified pistols, or we can say Parkinson Roger, which is the lateral pancreatic cholecystectomy, and then another type of resection procedure is a phrase in which we do coring up the head. Then vigorous procedure, and if like there is malignancy or the pancreatic head is quite enlarged, then we go for the pancreatic duodenectomy. Every procedure has its own like benefits and drawbacks. Suppose if we are going just like a pancreatic duodenectomy, the morbidity is less. Both like endocrine as well as the exocrine functions are maintained. But the issue is that if we are not properly draining the head part, then there can be again like recurrence, or we can say patient can present with the same symptoms. With the resection procedures, the problem is that there is quite a high morbidity as well as mortality. Next, now I want to demonstrate a video here which we have done in our department. He was a patient, about 40 years old male patient. He was a no stop here. He was known as what history? Slide. He was a known case of chronic calcific pancreatitis. Patient was fully evaluated. He was diabetic also and a chronic smoker. This patient was not responding to our conservative treatment, but he had a dilated pancreatic duct around 7 millimeters. Then the decision was taken to go for laparoscopic lateral pancreatic cholecystectomy. Let's play the video, please. To start with, the first step is that we have to enter the lesser sac. This can be done only by dividing the gastropotic ligament, as you can see here, by using the energy device to expose the pancreas. Once we reach the pancreas by using these, you can see pancreas exposed. Now the important step is here, how can we localize this pancreatic duct? There are different strategies. Ideally, we should have used endoscopic ultrasound, which we don't have available here. This is one of the methods for the demonstration purposes. We have put in a hypodermic needle transabdominally into the pancreatic duct for the localization of that. Once we are sure that this is the pancreatic duct here, we just make an incision over here, and you can see like because of long standing inflammation, what happens there, lot of pent up secretions are coming out, and the fluid is coming out of this. Now the surgeon is using same energy source to extend the duct artery further towards the tail region, so that the duct is properly exposed. But here you have to be careful about hemostasis also. Now again, like you can see, a lot of fluid is coming out. The same ductotomy incision is now being extended further. Meanwhile, we are also giving some saline flushes to clean the duct. Now, in short time period, you can see here, there is a calculus inside the pancreatic duct that will be removed shortly by using the endo instruments. The stone is being removed. This was the main culprit here. This was giving problem to the patient. Because of this, there was excessive pain, because definitely the intraductal pressure could have been high. Now again, to be very sure here, we have to give flashes again to remove any remaining debris and residual stuff. Now we are preparing the jejunal lymph. We go 30 centimeters from the ligamentum down. This is the ruling. The opening is being made in the mesentery. Now you can see using the same instruments where we are making an opening in the mesocolon just lateral to the middle colic vessels to prevent any injury. The rule is being taken off through the same opening into the supracolic compartment for the anastomosis with the pancreatic duct. Ideally, first we should have done here jejunal-pancreatic anastomosis, but here first we are doing jejunal anastomosis. It depends on the expertise of the surgeon also. Again, enterotomy is being made in the jejunum using the same linear endostapler. We are doing the jejunal anastomosis to maintain the continuity of the jejunum. Now the remaining enterotomy part is being closed using the 3-0 detox suture to achieve proper hemostasis and prevent any leaks. Now let's go to the part of pancreatic jejunectomy here. You can see the jejunum is being opened up in longitudinal direction by using energy device. Here we have to be a bit careful, like if we are opening the jejunum, it should be slightly less in linear as compared to that in the pancreas, because we all know jejunum is a bit it's elastic. Now we are going to the anastomosis part. Here we have started the posterior layer anastomosis, but by again using the same vlog suture. As we all know, the intracorporeal suture is not so easy. We have to be very careful while we are taking mucosa to mucosa bites. We have to take good bites to prevent any post-operative leaks. As we all know, the laparoscopic, we prefer laparoscopy these days. It takes time. The anastomosis is going on. We are doing the posterior layer anastomosis. As we all know, like laparoscopy is going up these days because of so many advantages. Previously, like in open surgeries, we have to do big incisions and lot of morbidity to the patient. And the advantage of laparoscopy is also less hospital stays, there are less pains there. We can isolate these patients as early as possible. So the overall complications like DVT are less in laparoscopic surgeries because of early ambulation also. Now you can see again the anastomosis is being done. Anterior layer has been started again by using the same V-lock suture. Some of the bleeding is minimum there, but we are able to achieve hemostasis. Almost right now, anterior layer also will be done in a few seconds. This is done. Then depending upon the in the post-operative period for the monitoring purposes, usually we start oral by second or third post-operative day and we ambulate these patients. Overall, we are getting very good results by these procedures. Thank you very much.
For your superb demonstration, video demonstration and detailed deliberation on the chronic pancreatitis. So there will be no session, we were short of time, no questions. So we call the next speaker.
Now we'll have
second session.
So just want to comment. When I was a postgraduate here in 90s, so there were only few surgeons who do Whipple's or biliary injuries. Now it's heartening to see that all the units are doing Whipple's and complex injuries. And not that only, the referrals are very less and the results are very good. And doing a laparoscopic Whipple's or CBD reconstruction, it is a very commendable job. So I congratulate head of the department or head of the unit. So I hope in the future you continue to do much more.
Reflect on the circular anatomy and it was also mostly on the congenital anomalies of the and we highlight liver pancreas and the pancreas. The second one is CCP. I think we should really have a debate that how should we approach a patient on CCP, because it's nothing like surgery, nothing like medical treatment. I think every patient has to be tailored what is available within our place and also how we can use the test. Suppose this patient is under discussion. I would like to have this patient had probably 2 stones or 1 stone. 2 stones. And I didn't see the pancreatogram. Was any pancreatogram available?
so MRCP was done.
What was it? There was stricture. What was there?
One stricture near the neck.
Dilated duct was there.
What you would see that this hospital also has a lot of mechanical receptors. It is a single stone and there is a stricture there. Okay, surgically she can remove, but it is the ideal candidate for the medical. Normally, if you see primary indication for being a surgeon, if you've got multiple strictures, if your stones trapped in the body and the tail, I think this is really a juicy patient for any medical treatment to have a mechanical lithotripsy, and you can just leave and just pancreatic splenectomy and just leave the patient. There was one study which was published in the English Journal of Medicine. It was heavily criticized because of many reasons. I think somebody wants to discuss why they showed that surgery is better than medical. But I would say no. Both are important. Both are complementary. There are many patients who cannot be helped by it. After many a lot of experience in the institute who has operated more than 100 patients at that time. We followed them. And both are good. But I would say we should always see that surgery, why to do surgery, why to do it. The second thing is the enzyme, other thing, they don't have bigger role. They don't have, everybody writes enzymes and very costly treatment for these patients. But yes, the patient has a demonstrable exocrine insufficiency, that time is wonderful. It's really wonderful. And it's a pain. Otherwise, you don't give it. It's a pain, it may help and other antioxidant and antioxidant. A very important thing in our place, in Kashmir, I think we have to also see that many of these patients, at least 7% patients, they develop malignancy. Even if you do medical treatment, surgical treatment, you are not to leave them. You have to follow them by serum imaging and also by tumor markers. Their malignancy can be very, very bad and they can 7%, it's a big number, 7%. And second thing also, I probably the surgeon may talk about inflammatory masses.
in the head.
What somebody said about the size of the head, that's very important. Because that is a pain. Pain part can be taken care of. If you do the coating of the head, that time surgical thing is very, very important. And I know, I think, I don't know whether you remember that we have presented 5 patients who were diagnosed with malignancy. And unfortunately, with the cytologist of malignancy, they lived a long life. And it was eventually only the inflammatory mass. I think that has to be also taken into care.
Relevant and Professor Shaukat, very young, when she entered into the subject. I was also very fortunate to be associated with him for about 35 years, more than that. And very closely monitoring each other, growing and senior also. But then such meetings, what he says are the fruit of that. I think the wisdom is what he said is that individually tailored. I'm certain that we, during his tenure as director, I tested him for making a pancreatic club, which he allowed and the papers were weak because I had to request the head of the department whether they should for making something outside the institute. But I think time has come that we should, because these are vast things. And this is chronic calcific pancreatitis, he's talking, he talks very well. And I was very fortunate to have her with me because I was a PG guy. So seeing that shift of into pancreatic surgery is a dream. You know, understand. He talked about Professor Vani was a legend, there's no doubt about it. One of the finest surgeons I have seen. But I was fortunate as a young man to work with him. Well, it was not easy to work with him. But then again, seeing the shift in thinking, and Professor Shaukat put me to portal hypertension. That was 1997, 98. He threw me there. And rather, because there were a lot of patients traveling outside. So we came with a challenge. We started doing it. He was heading the department. Actually, he is a critic. Then only the criticism makes you to do good work. That's what makes you and breaks you. We formed a good department, good series, what's he talking about now, hundreds of patients together. We studied the phenomena epibdju in choledochal cysts. I was very fortunate to see Kimisaras. You can talk about 2 Japanese classifications. We did choledochal cysts from this place, which is regarded as one of the finest series in the world, and referred to in Bloomberg together. That was out of his experience for ERCPs and giving me the ERCPs, about 70 that time, I analyzed, seeing the junction. What I mean to say is that what Professor Shaukat is saying, that we have to take it seriously. The outcome of this meeting, this is what I was telling Professor Kuru one day. He called me some long back, why don't you do this there? I told him that the house is not in order. That time Professor Hamid Saab was the director. There were some issues with the operation theatre. The house has to be in order first. You have to do things here. Then you go out. It doesn't matter. Nobody will ask you here what you are doing. We will ask you what you are doing. We know each other. Once Professor Shaukat speaks about somebody doing good work, that means he must be good. He will not talk unnecessarily at his home. He will tell him, no, 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 you are not doing that. Then he cannot be Professor Shaukat. What is he today? Thank you very much.
Yeah, because they are all big wigs in the surgical fraternity in human catchment in the country also. I know not much about Dr. Shaukat because he was a physician. तो जब मैं वहाँ पे काम कर रहा था वहाँ फिजिशियन को फराहम करना भी मना था। लेकिन की बात है, लेकिन मैं ये बता सकता हूँ, had they been in the West, Umar, Dr. Iqbal, and all of you actually, Dr. Iqbal and Dr. Antri and so many other people, and they would have been big names in the surgical circle of the whole world. But unfortunately, we belong to a very poor part of the country, and therefore their name is not as much publicized as it should have been. But that doesn't matter. The commendable work they are doing is very, very big thing, and they contribute to the world literature. From Sora, and I am happy to say that all people working in Sora are products of GMC Srinagar. And in fact, the new medical college also from GMC Srinagar. There's nobody who is out of GMC at the moment. There may be in 50 years from now, there may be a change, but till then, GMC is the supreme commander of all this medical college or the medical fraternity. And second thing is, because I do not want to go into this subject, and this is the whipples that they were talking about. There was one big name in surgery in the whole of the country, that is Dr. Mahmouda Khan. And in those days, Umar was also here. She was performing Whipple's surgery, although it was under routine. But she's the one I have seen doing Whipple's surgery. I'm proud to have seen that as a very junior student of medical college, Srinagar. And Umar must have also worked, and many other people ventured into the area. But they were few and far between. When institute was established, and it got a big boost in the form of Professor Vani, Professor Kuru, Professor Dargar, and so many other names. It's so difficult to name everybody, and they contributed a lot to the development of surgical gastroenterology in Kashmir, in Jammu and Kashmir, and probably one of the best quoted authors of these surgeries in India, at least in India, if not Bangalore, alone. I mean, they are all over the world, and it's a good time. Umar has the largest series of this thing. The second, but I must, because there are so these people are not here. We were fortunate to have Dr. Mudassir was working with Mudassir Akhtar, and it was something called charges both of them. And in those small period of time, because I left this place at that time, we had done about 6 to 10 Whipple's operations in that 1 year. That 1 year, and they were all successful. I mean, there was no mortality. But that was the beginning. And laparoscopy has come. It's not the end in itself. The technology grows so very fast that at one point in time, in very near future, I dream of a patient getting into a machine, every cell getting scanned by the technology and getting treated on spot, and after 2 minutes the patient comes back with his report and he's taken up. The laparoscopy will go into the oblivion, open surgery also go into oblivion, so we'll go to CT and everybody else. I hope this time comes sooner than later. Third thing is I must come with Dr. Iqbal, because I was observed, because I have of the opinion, अब surgery के अच्छे दिन आ गए. Dr. Iqbal कहने से, I told everybody he's doing this. That I like, but which is in me too. He's very enthusiastic and he's very emotional. These people succeed in surgery. And when we had laparoscopy, this is the first place to have laparoscopy in Jammu Kashmir. And Dr. Munir Khan, he is the father of laparoscopy in Kashmir. He went on his own, did a training in Bombay for 1 month on canines, and came here, and all of us were seeing him performing laparoscopy. He is an excellent laparoscopic surgeon, and I salute him for his diligence and for his perseverance. Rest of us, we were loitering around in the plants and in the gardens and going to canteen, sitting tea. He was the first to organize conferences, get guests from outside, and then things happen. Then, luckily, I was not a laparoscopic surgeon. I had gone to a brief training in Jammu, private hospital, where AIMS people came, Gangaram people came, and they taught us. But the rare laparoscopy I saw when Dr. Iqbal was luckily posted in my भगवान से दुआ करते हैं जब ये ज्वाइन किया कि हमारे में आना चाहिए because I was very busy I was eager for laparoscopy I was young and I wanted to learn and it happened God answered my yes and he came to, and we started we faced difficulties initially in administrative difficulty we were allowed to do laparoscopy after one and after one anesthesiologist said oh no laparoscopy now please now बहुत होगा इसको postpone करो मगर things don't stay there. Then you add, and he worked very hard after a while, I must say. But we had a very brief stint together when he was shifted from a unit. But things did not stop there. Everybody came to shoot laparoscopy. Because I suffered, I wanted to do laparoscopy, I wasn't permitted. For many reasons. I was not a great surgeon, like they are. So, but then everybody picked up, went into the wheel, and watched everybody, Iqbal, and then came Atri. Atri is a master surgeon in laparoscopy. I mean, after Iqbal Sahab, Atri Sahab is the rest.
Chalku sir also.
Yeah, of course, I didn't say, but it's because ये Dr. Sahab, you know, Chalku Sahab तो बाहर से ट्रेन करके मेरे साथ बहुत बड़ा काम किया और बड़े enthusiastic थे. Because I was talking about HOD, head of the department of Iqbal Salim. I know him very, very thoroughly well. We were together once he was intern, and in those bad days, when this and we were playing TT. I was a PT scholar, we had no work except the bullet and we used to play TT in their canteen. And I know him from those days. His enthusiasm, his commitment, and his very eager to learn and know and practice it and master it. I salute him for his leadership. He's a long period to go as head of the department, and and all these people, Dr. Zarga, Dr. Kuru, Dr. everybody who has been, Dr. Mahmouda, and Dr. Omar, and Dr. Ejaz still in government job, and Bakar, and Atri, and Iqbal, and Jalku, and so many others. He has been their colleagues, Dr. Awan, and they are treasures of knowledge. You must suck them dry before I won't say too much, but I have to talk a lot. But I would say last of all, I would say, sir, Dr. Iqbal, GMC Srinagar is the center of knowledge. Skin is a child of GMC Srinagar. I am proud to say, hey, bacha to tadi kar sakta hai na. They went into super specialty. We didn't have a concept of super specialty here. Now that we have there, we also grow at a very fast pace as they did, and under their guidance and supervision and their help. But this is incomplete. You are sharing this knowledge in the four walls of this auditorium. There are now medical colleges in Islamabad, in Baramulla, and Handwara, and Jammu mein bahut se colleges hain. This knowledge must be shared with them too. Because with the objective that the standard of medical education must be uniform all over the place. And GMC Srinagar has to take a leading role. इसलिए मेरी आपसे विनती है, मैं आज हंदवारा में हूँ, and definitely we like to see you all in Handwara. But technology is there. You just have to have a lecture here, transmit through this to our place. There will be audience who will listen to you, and vice versa.
Thank you, sir.
If that is done, it will be a great step and great favor to the medical education and our own people. Because मैं उमर को याद करना चाहता हूँ, उमर साहब, आप कितने बड़े सर्जन हैं, खुदा ना खास्ता अगर उनको भी सर्जरी की जरूरत पड़ेगी, आपकी हमने शेयर किया
I invite the chairperson for a panel.
Chairperson, thank you बोलेंगे. बोलो.
Thank you.
Even if you are working better than we know what is important. You should know that this is very, very important. Whatever you may do hundreds and thousands of cases. I think you have to learn that art of writing also, which make you visible, not in national and international level, by the world. Now, I'm the product of this college. I think there are a lot of huge material. I think people may or may not acknowledge. whole medicine got changed in this. There was a shift in the whole valley and even the Jammu and whole state because of schemes. The reason was because not there were big people there. There were facilities, there were commitment, and now you look everywhere. Now if you look at the medical college, I came here, I think it was 2012. I asked one person, why don't you allow these subspecialties without any? Because actually had very accommodating. The juniors have to respect the seniors, and the senior should give a space to the seniors. That's very important. If he doesn't give the space to juniors, he will never do it. But at the same time, the senior has to respect and those departments probably. And today, at least I know, there are many departments in the GMC Srinagar, they are better than skills. They are definitely better. I'm not doing the department, but I know you, they are better than skills. Suppose you have started laparoscopic or the pancreas, it was a dream once a time. After the first you present the case, it's very nice. So I think it has to go out. And I would like to urge the head of department of the secretary, there is a lot of pancreatitis in this hospital. Because I see a lot of patients. Probably because you don't mind, upgrade the medicine. A lot has come for the pancreatitis. It's not the same disease, but it's totally different. And I think this hospital can publish a lot of material from pancreatitis. You must be getting every day 4 or 5. At least 4 or 5. So I think you should work here. And I would like to sort of tell the juniors, you should publish. They go on publishing, and whatever they say, you should publish. Thank you very much.
I thank the chairperson for their valuable words and for chairing the first session. Now we would like to start the second session. I request Professor Umar Javed Shah sir, former Director Schemes, Professor Ejaz Malik, HOD General Surgery Schemes, and Professor Hakeem Waqas, HOD Department of General Surgery, GMC Srinagar. Kindly chair the session. I request Dr. Asif Mehraj to come to the dais and present laparoscopic management of distal pancreatic tumors.
Respected chairpersons, head of the department, respected professors, my teachers, colleagues, and dear students. Very good afternoon to all of you. So, we'll be presenting the laparoscopic management of distal pancreatic tumors today. So, it's on behalf of our surgical unit 5 from the Department of Surgery. So again, since the theme of the today's program is on the benign tumors of pancreas, and we'll be concentrating on the distal pancreas. So, my previous colleague, okay, Irfan, has already talked about the anatomy of the pancreas, so I'll not go into the details. And functions of the pancreas, we know it's a mixed exocrine and endocrine organ of the body. So it has a lot of functions and physiological importance in the body. So besides its strategic location, as we can call it, it has an important physiological function as well. So any surgery or any disease of the pancreas, it has a paramount importance in the daily homeostasis of the patients. So going directly to the pancreatectomies, so we have different types of pancreatectomies that we as surgeons can have. So we have distal pancreatectomy, where we resect the tail, body, and maybe the neck of the pancreas just to the left of the superior mesenteric vein. Then we can have total pancreatectomy, wherein we remove all of the whole of the pancreas, and the Whipple's procedure, or what we call as pancreaticoduodenectomy. Besides, we also have central pancreatectomy, which can be, though very rarely done, for some specific causes only. Then coming to the distal pancreatectomy, so we have so many varied indications for performing these distal pancreatectomies, right, beginning from various inflammatory reasons, through benign tumors, different types of benign tumors, they may be cystadenomas, different types of cystadenomas, serous, the mucinous, the intrapapillary neoplasms. Then we have those neuroendocrine tumors, and even for some adenocarcinomas of the pancreas, or for trauma as well, we can perform distal pancreatectomies. So the concept of laparoscopic or the minimal access pancreatectomy was given way back in '96 when Gardner reported their initial series of minimally invasive laparoscopic resections. And then there was a review published just in 2016, just a few years back, where they said that the minimal invasive distal pancreatectomy should be the standard of care in managing any benign pancreatic lesion in the distal pancreas. Then there was this Miami International Convention wherein they gave those guidelines, and they suggest that minimal invasive distal pancreatectomy should be considered above, like it's better than the open distal pancreatectomy for benign and low-grade malignant tumors, and this has a scientific evidence to prove it has grade 1B evidence. Then even recently, just last month, there was this paper published in Lancet, and they say even for malignant tumors of the distal pancreas, the laparoscopic or the minimal invasive approach is non-inferior to open surgery. So why are we afraid of performing a pancreatic surgery? Like there are some complications which are very notorious, and one of them is a pancreatic fistula, post-operative pancreatic fistulas. So these complications and the strategic location where the pancreas is located, because of the close vicinity of so many important structures and so many important organs, the blood vessels. So this makes pancreas a very strategic organ, wherein we have to be very careful while we are tackling any surgical intervention on this organ. So there are various complications: pancreatic fistulas, gastroparesis, bleeding, infections can be there. Then one important physiological, these are the anatomical complications, one important physiological classification that we should be worried about is the diabetes. Though the islet cells, they are distributed evenly throughout the body of the pancreas. We're talking about the distal pancreas. So the islet cells are distributed throughout the pancreas, but there is a lot of variation in the incidence that has been reported in the literature. Some of the papers suggest incidence as low as 8%, and some of the papers suggest incidence as high as 60% of diabetes in pancreatic resection. So then there are other complications as well. Then once we are performing laparoscopic pancreatectomy, distal pancreatectomy, it has been shown in the literature that the spleen preservation rates are more in laparoscopic approach as compared to open approach. Then once we are doing spleen preservation, there are two surgical techniques which are reported in the literature: the Kaimura technique and the Warsaw technique. In Kaimura technique, we preserve the vessels, the splenic vein and the splenic artery, and the gastrosplenic arcade. While as in Warsaw technique, what we can do is we leave the spleen on the gastrosplenic vessels and ligate the splenic vessels proximally. So it can be done in two ways. Either we can do it on table, we can just put bulldog clamps, check for the vascularity, ligate the vessels proximally, and check for the vascularity, whether the spleen develops infarct or not. If that's not the case, we can go ahead with spleen preservation. Or even in some 10% of the cases, we can just safely ligate the vessel. Only in 10% of the cases, there may be an infarction in the spleen, which may need a secondary intervention. Then conventionally, if we look, we are going to this surgical aspect only. So technical aspects of the distal pancreatectomy. So conventionally, we see. I'm sorry, the pointer is not working on this specific DVD player, this thing, monitor. So we look. We conventionally use the umbilical port as an optical port. We use a 12 mm. The second port, again the working port, right hand main port is again a 12 mm port, and the left hand port is a 5 mm, and we can use an accessory port is a 5 mm port in the left hypochondria. And some people use a 5 mm in the epigastric as well. But what we have also, I'll come to that, the position of the surgeon again, there are again varied positions. Either the surgeon can stand on the right of the patient, or the surgeon may stand in between the legs. So it's always wise to have this wider part of position so that we can adjust while sometimes we may have to do a proximal dissection. So a position between the legs, the French position will be better that way. So what we have developed, the different modification, but we have modified our technique. We don't use that 5 mm port, the epigastric port. So I'll show you in the video how we have modified that port. So this is a patient, I'm going to present a video. There was this patient, I'm sorry, again there's not a pointer. So we have this patient who has a distal, there's a cystic mass in relation to the tail of the pancreas. So there is a doubtful communication with the pancreatic duct. So this patient, since the gold standard for differentiating a serous from a mucinous cystadenoma is an endo-ultrasound and endo-ultrasound guided FNA. We can use certain tumor markers, and there are some cytological markers, other cytological markers that we can use other than the biopsy that can guide us whether the tumor is benign, whether the tumor is serous or a mucinous adenoma. But since we don't have a facility of those facilities available here, so any tumor which is more than 5 centimeters, even if it's a 5 centimeter serous adenoma, and the patient was symptomatic. It was a young girl who was symptomatic. She was having a lot of pain. She was not relieved after taking so many medicines. So we took her for the surgery. I'll come back to the post-operative pictures later. So directly going on to the video. I welcome our worthy principal, Karmir Masood sir. Very honored to have you, sir. So again, in this patient, as I said, the port positions are varied, and there is no standard port position. So it depends on the surgeon's convenience wherever we want to put the ports. So we first do diagnostic laparoscopy. We look at the liver, we look at the stomach, we look at the pelvis and the peritoneum. Then the first step for performing a distal pancreatectomy is like we remove the gastrosplenic ligament, and then we are lucky enough to have different types of electrocartilage, the energy sources in our department, thanks to our HOD and thanks to our administration. We have all energy sources, whatever gadgetry, modern gadgetry you talk about, we have all of those gadgetry.
Except robot.
Except robot. So this is a modified technique, what I was talking about. So we make a gastric hitch. Instead of using that extra epigastric port, we hitch the stomach to the parietal wall. Now you can see there is a tumor in the distal end of the pancreas, which is closely adherent to the posterior wall of the stomach, which is adherent to the colon, and which is adherent to the below. Because see, now the first step, what we are doing is the release of the splenic flexure. So the splenic flexure of the colon needs to be mobilized and brought down so that we have a proper access to the tail of the pancreas. we are using a vessel sealer device. It's a bipolar device. You will see there is no blood in the surgery. This is the technology that helps us. Tools are very important for us, but the man behind the tools is more important. A man with a tool is a fool with a tool is still a fool. So, unless and until you have brain, unless and until you don't have a knowledge of the subject, you can't do well. Now you see, we have mobilized the splenic flexure. Now we are going on the inferior aspect of the pancreas. Now the fourth layer of the mesocolon is firmly adherent to the lower border of the pancreas. So we are separating the mesocolon from the pancreas. And see, once we are lifting the pancreas up, you can see the inferior mesenteric vein and the splenic vein confluence going there. And we have to be very, technically, surgeon has to be very sound to to go in that area, because all the important veins, if there is an injury to the inferior mesenteric vein, or if there is an injury to the splenic vein, you have to remove the spleen. So you have to be very meticulous while performing any dissection at that point in the surgery. So you can see that is the tumor on that side, distally, and you have the yellowish, you can see the pancreas, and we are trying to make a posterior tunnel behind the pancreas. Again, you can, so gauze, again, as a surgeon for the junior colleagues, it's very important to have a gauze in place. It's really a wonderful assistant, I should say, in while performing such types of complex surgery. So you can see the left gastric, it's going up into the stomach. So many important structures there, and very meticulously using a combination of energy device. Again, we are using a harmonic scalpel here. Earlier we are using an NCL. So all the facilities that we have available here. Now here you can see once we come above from the superior approach, you will see the splenic artery first. But if you go from below, you will see the splenic vein. So we are trying to separate the capsule. Then again, you will see mobilizing it fully from the adhesions. This is the tumor that we are trying to, from the splenic, gastrosplenic and the splenocolic ligament, we are trying to release it, trying to preserve the spleen. That's the main important thing here. We're trying to preserve the spleen. Otherwise, there are indications like for distal pancreas, usually spleen is taken along, just because technically it's very difficult. But once you have a better technique, once you have very good expertise, you can preserve other organs there as well. So again, we are just dissecting from the vital structures. You can see the main vessels going on the inferior aspect. So again, you can see that now the splenic vein is going right across the upper border, superior border of the pancreas. Now again, we are trying to prepare the staple line for the transection. It's important to remove the capsule of the pancreas so that your staples will hold firmly. So again, you see, the splenic vein, it's closely abutting the surface of the pancreas, the superior surface of the pancreas. So it's very technically difficult. It actually runs in the pancreatic parenchyma. So it's difficult technically to separate the splenic vein or the splenic vessels from the pancreas. And here you can see we're separating this splenic vein, which is a long tortuous vein, and we're separating it from the pancreas. And it's all along the length of the pancreas that we are doing it. It's not just the line of transection only, but all along the length of the pancreas that we are doing it. Also, there are branches from the splenic vessels, the greater splenic vein, the dorsal splenic vein. So they all have to be preserved as well. So again, we are ensuring that we remove whole of the spleen, that tumor, and do not leave any part of the tumor behind. So again, meticulous dissection, making sure that the splenic vessels are preserved. So again, now we are making a tunnel and pulling the line of transection using a feeding tube, and then firing a stapler. So we are using a golden cartridge here. So it can vary. Some people use blue, some people use green. It depends on the thickness of your pancreas. So it has been shown that the thickness of the pancreas is one of the most important predictive factor for your post-operative pancreatic fistulas. So pancreas more than 17 mm has been shown in literature. They are more prone to develop post-operative fistulas, and there have been so many strategies to prevent post-operative pancreatic fistula formation, like pre-operative stenting, pre-operative sphincterotomies, using glues and other things. So we have resected the tumor and just checking the vascularity of the spleen. It's intact. Just checking for hemostasis. All the hemostasis is excellent. And just put in some sponge on the gel foam on the pancreatic stump. And to achieve the hemostasis. So we then remove the specimen intact and just put in a drain there to complete our surgery. So this is the post-operative picture. So you can see the patient. We have used the extraction port, at the 12 mm port, and put in a drain from that side. And you can see the specimen, the resected specimen of the patient. So this is a journey which has started. I will not say we have reached very far, but we have begun our study. And as they say, journey well begun is half done. So we hope that with the support of all of you, we'll go ahead in doing such and such more complex surgeries in future. Thank you very much.
What was the histology of this?
So it was a serous adenoma.
Nice presentation, Asif. Excellent dissection. I would compliment you for that. But I will correct you also. Splenic vein is not understand the terminology, once you get into that area. And it grooves the backside of pancreas. It grooves. The terminology is that. While the splenic artery is tortuous, because spleen has to be here and there like this. So nature has provided the tortuous. It's like snake. This is very important term. And splenic artery is superiorly placed, while a splenic vein is posteriorly placed. These are anatomical terms, but you presented it very well. And the dissection was like what's for everyone. I must compliment the. It's the time to compliment the present administration. That they are doing wonderful work. And laparoscopically, they have advanced, as Professor Shaukat also has substantiated, that they have advanced. Certainly, they have advanced. I remember Professor Shaukat gave me laparoscope as a director. He handed over to me in 2010, 2011. I was not a laparoscopist. Pancreas was not done that time. So my focus was that I handed over to the next person. The lady, that it is yours, you show the results. But he caught hold of me after a few years. He told me that there will be an audit, if he remembers all this, and that is correct administration. Have you used the equipment properly? Which I still remember, I could not find my answers right. But then I had my own mind also. I had handed over practically. So the equipment, whatever you said, government has given you, the administration has to answer all the time. And they have to have a lot of sleepless nights from that. So So the whole credit goes to the administration first, and of course using it on the patient, and patient giving you the prayers goes first to you. And that.
I may add a few points here. A very good meet all of you. And thanks for the invitation for inviting me here. For these partners, for professors here. It's really indeed a very good, nice moment to see that Foreign Medical College, our hospital, the first place where we all have been born, is doing so much excellent work in minimal access. See, minimal access surgery is the test of time, and it has to go forwards, and I feel that within a period of 1 or 2 decades, open surgery will be replaced with minimal access. But nowadays, you see, there have to be, whenever you venture into a new area, you need to have and follow certain principles and guidelines. It is not always that you can venture laparoscopic or minimal access surgery in all the cases. There are still so many cases where you may not be able to do minimal access and you might have to convert. So positivity should not always be shown. You may have to do an open surgery, or you may have to convert. You may meet an accidental iatrogenic injury or something which may make you to open. So what message is to be given to the youngsters? That you need not to worry. You need to know to manage such complications, to detect them and manage such complications as well. It may be in initial phases laparoscopically, but sometimes you may need to convert. And at the time of conversion, you should never have a deterrent that you are converting because I have now made up my mind. This is one. Second thing, what I have found in both the places, skins have been doing work right from its state of inception. All these people have been people who have administered that area. Nothing is possible without a combined effort of all the administrators, the heads of the departments, the consultants. Ultimately, whatever job you are going to publish is basically the work of these people. And they all need to be appreciated. There's not a single person who needs, because it's a combined effort of all the people. I can feel how many juniors are involved in surgical procedures, and nobody names them. So we should appreciate everybody, because this is a team work. It is not a single man's job. Third thing, minimal access has really gained a momentum at all the places. I'm happy. I can talk of my place here. Maybe things are not known to all. Some of the people have worked with us. Almost we are doing everything now minimal access. There's no procedure which we may not be doing minimal access. And number two, it is all efforts of the people who are working there. And you need to have a little bit of diversification also, because everything cannot be done by a single person. So you need to have some areas where there's an exclusive work being done on a particular thing. GI surgery, colorectal, you have hepatobiliary, you have pancreatic, you have then endocrine, adrenals and other things you have. So many things are there. So everybody has not to venture in all the areas together. I think it is now time to diversify in this area also. Because only after a particular period of time, having a good number of cases in a particular area, you will have good experience and you will deliver the best to the patients for whom we are all after all. And one more thing is that I feel happy that we are having a mutual understanding, and we are inviting people from this place, and you are inviting people from that place. I'm really happy, and I think this has happened now mostly because of last 4 or 5 years only. There was little bit of wedge which we are trying to. Why that wedge was there, who has kept that, and what, I don't believe in that, but I take every person as a professional and a person who is giving the judgment, and then he is delivering something for the patient. Ultimately, patients are from our value and the reference. So we should join together hands, help the system to go far away, and meet all the demands, meet all the deficiencies, whatever we have. But at the same time, we have to put forward these things to the higher ups in order to have better things in future. Thank you.
Thank you, sir. Next up, we have laparoscopic management of pseudocyst pancreas, presented by Professor Abdul Rashid Ganai, sir, Head of Surgery.
Respected Principal Sir, Head of Department Surgery, Dr. Iqbal, Professor Iqbal Sir, and other dignitaries, Assalamu alaikum. Good afternoon. The topic which has been assigned to me is pseudocyst pancreas. The cyst is pseudo, presentation is true. As you know that the pseudocyst is a fluid collection contained within a well-defined capsule of fibers or radiation tissue, or it may be a combination of both. It does not possess any epithelial lining, may develop in the setting of acute or chronic pancreatitis or after pancreatic trauma. The common size is lesser cell, though it can occur anywhere, as from mediastinum to the scrotum, and the size also varies. Then it may be located or may not be. The most common presentation of pseudocyst pancreas is abdominal pain, vivid abdominal pain. The other presentations are nausea, vomiting, satiety, bloating, and the sizes may vary depending upon the presentation like non-infected, it may present only with some degree of tenderness, abdominal fullness, or as abdominal. The diagnosis is in addition to routine investigations, these are specific investigations which are being done for diagnosis. They have already been discussed today. If there is infection, these are the complications which can occur in the cyst. Infection, if it is there, the patient runs high fever, there is abdominal pain, and there are signs of sepsis. CT shows thickening or fibrous wall, or it may show air within the cavity. Even if you do a simple X-ray, that may show effusion in the chest, or it may show some air within the cavity. Then cyst may present as obstruction, or this may get complicated in the form of an obstruction. Many patients we see as this gastric outlet obstruction associated with the cyst, depending upon the site of the cyst. Then perforation may be there, hemorrhage, thrombosis, in which splenic vein is involved, and pseudoaneurysm formation may be. Management is the management algorithm. Acute pancreatitis, chronic pancreatitis, or alcoholism-related pancreatitis, or secondary trauma can all lead to the formation of pseudocyst. The management on pseudocyst varies. If the pseudocyst is generally we observe all these patients for a period of 6 weeks. Within this period, we come to know whether this is going to resolve or not. Some patients, even within a period of 1 week or 2 weeks, depending on the severity of the disease, show signs of inflammation in form of the colonion, which may resolve or lead to formation of cyst. This cyst we observe for a period of almost 6 weeks. It is not fixed in 6 weeks. We can have a week lesser or more. And if it is more than 6 centimeters in size, or if it increases in size, the management is intervention. If the cyst is less than 6 weeks old and it shows signs of resolution, patient has sense of well-being, appetite improves, tenderness decreases, and there is decrease in the size of the cyst. So we observe the patient. We can observe the patient not necessarily for these 6 months only. We can carry on observation as long as it is 6 months. It takes sometimes 50% of the patients with pseudocyst of pancreas resolve after only a period of time. But if there is a persistence of it, then intervention is needed. Then it depends upon the site of the cyst. If it is located in the tail of the pancreas, then if it is within the tail of pancreas or body of the pancreas or head of the pancreas, the management will change. If it is within the tail of the pancreas, we will go for excision or distal pancreatectomy. Then other cysts we may do internal drainage or external drainage, which has their own indications. The external drainage usually we do in complicated patients who have their secondary infection, there is pus, so patient will not necessarily a favorable patient for internal drainage. In such situations we do external drainage. That can be in the form of percutaneous drainage or surgical drainage. The internal drainage, endoscopic drainage is preferred one, and second is laparoscopy, and then open drainage. The endoscopic drainage, most of the time is done by gastroenterologist CSEP. It has its own indication, we will not go into the details. And then the laparoscopy is a principal topic for us today. We will go for the laparoscopy. So pancreatic dissection, let's have again this cyst, if it is in the body or tail of the pancreas, then if the complex cyst in the head or pancreatic pseudoinjury is there, then distal pancreatectomy is the treatment of choice or surgical modality of choice. If it is in the proximal, we may have to go for a big procedure like nuclear. Then if the cyst has ruptured, we may have to go for external drainage. So if the cyst is complete, the internal drainage, there are certain criteria which are required to be fulfilled. General surgery, as such, requires a general surgeon, we require to stick to certain basic principles regarding the management of internal drainage. The most important thing is that the drainage has to be dependent. Whether it is open drainage or it is laparoscopic drainage, it has to be dependent. Second is, all the dirty has to be removed. Hemostasis has to be maintained after the procedure, and in the post-op period also there is to ensure that there is no bleeding. Then the cyst wall has to be in approximation with the stomach wall, so that the drainage procedure becomes easier and faster. Then biopsy is very important in these cases. That is not possible by endoscopy, that is possible by laparoscopy or open surgery. In laparoscopy, drainage of pancreatic pseudocyst, there are three ways. One is intragastric cyst, gastrostomy approved. Here what we do, after creating pneumoperitoneum, pressure is maintained usually at 8 to 10 millimeters, and then ports are made with stomach wall also. There is an intragastric tube placed that insufflates the stomach. So 3 ports are made. 2 ports are made as working ports for the surgeon, and 1 port for the camera. Once we see the interior of the stomach, then we see the bulge posteriorly, and then we go for the puncture of the cyst. Once puncture is done, the fluid is drained, and then the opening is made bigger with the help of cartridge or any energy device. Then once the opening is made bigger, usually 4 to 5 centimeters opening is made, and then the stapler is placed here and the anesthesia. Then all the damages is sucked out, irrigation is done, tube is placed in the stomach, and the 4 sides which are usually on stomach they are closed with the allopapic suture with the figure of 8. Then the abdominal ports are closed as usual. There have been some modification also. Some people don't create pneumoperitoneum. They directly hit the stomach to the parietal wall and go directly into the stomach. But that is cumbersome and very difficult. Sometimes there may be bleeding so much that you may have to resort to the open tech. So that is not much in the road now. The second procedure is anterior transgastric. This is most of the time done by majority of the surgery. Procedure is preferred. The advantage is that directly you can see the anterior wall of the stomach and make an opening 5-6 centimeters. The opening is made in the interior stomach wall, and once the opening is made, the bulge is seen in the posterior wall. The laparoscope is introduced, and the suction apparatus is introduced. Then the opening is made in the cyst wall on posterior wall of the stomach. The problem with this procedure is that there is spillover of the contents of the stomach, and that's the only issue with this type of procedure. And anterior gastroctomy, then two gastroctomies, posteriorly one and anteriorly one. These are the disadvantages. Then third is this, to go through the lesser sac. What is done is that once lesser sac is approached, the limit between the stomach and the lesser sac is identified, and a small incision is made in the cyst wall, pseudocyst wall. So once fluid comes out through the same opening, a stapler is introduced and cystogastroctomy is done. Then this is most reliable method of or the technique of doing this cystogastroctomy, but the problem is it is a bit technically difficult. Then we have cystogenostomy. Here, after reaching the lesser sac, clearing the stomach, interior surface of the tissues and the abdomen, this limb of the duodenum is taken almost 30 centimeters from the D-gate, and that is anastomosed to the sac with the help of this either with the hand sewn or with the help of the staplers. So this is, we can see here, two ports. This is a cyst, and there are these procars directly into the intracystic cystogastroctomy. So these sometimes people use 3 ports. They are using only 2 in this album, but 3 are being used, and you can see inferior to pancreatic and cyst, and inferior these are 2 ports. So this is the video we have. Anterior transgastric approach. So this is anterior transgastric approach. These are the post pancreatic divisions. Two cysts with trachea. These are divisions where the disease or momentum. Then division. And this part is being used. This transparent ligament is being used to have better access to the area. Again, these are ready, and anterior surface of the stomach is visualizing. And a small gastroctomy is made with the help of the anatosomes. Opening is widened. And this is maintained. The interior of the stomach is the next visualizing. So this is the cyst. Posterior wall also cyst wall. And the cyst is open. Here I started. Splitting out of the cyst. So this opening is made bigger and bigger. You can introduce a stapler device, venous stapler. So this is venous stapler which we are using. For then expose the cyst wall to the posterior stomach wall. Expose is complete, irrigation is done now. The severity is taken out.
This was a wonderful presentation, a very elaborate presentation about the management of cirrhosis and managing it laparoscopically. You people are doing a wonderful job in a wide spectrum of venturing into pancreas laparoscopically, minimally invasive. That is something, it's a great accomplishment. So, and very clandestine, you are raising the bar of the new medical colleges.
We will definitely be with you, always.
Yes, that's what we hope. We're looking forward to that. So congratulations to the whole spectrum, the whole faculty for doing such a wonderful job.
Thank you.
Thank you, sir. Now to conclude the Now, I would like to request Dr. Tanveer sir to please come on with the title
Teachers, distinguished faculty and students, good afternoon and assalamu alaikum to all of you. It's a great meeting for me that the Department of Surgery organizing such kind of events at short notice. I think it was at notice of 2 days.
3 days.
Few days ago and very now this level. I'm honored here. I was reminded of my student days, and I used to be a student of Professor Southwood. So let me take you off this. And we had some great stalwart teachers in those days on the medicine side. I can speak of them only. And one of them was Professor Kuru, who had the greatness of simplifying complex concepts to the level of absurdity. He would make extremely complex topics into simple topics. He would explain to us about hepatitis and all the key antigens and surface antigens and all those. That was his specialty. And then came Professor Shaukat. And you know what was his specialty? He would talk in percentage. What percentage of acute pancreatitis patients have ultrasound positive? What percentage are picked on CT? I am talking of, I think nearly 25 years ago. Such was the, what percentage of CBD stones are picked on ultrasound, on ERC, on CT, on MRC. So, what we had named him was that he speaks of percentages. Professor Shaukat used to speak of percentages. What percentage? I think he was the most scientific teacher of our era, and I would say, and similar category was Professor Hamid that he would also, but he had a different style. And I am very glad that the Department of Surgery has called such stalwarts as Professor Shaukat Saab, Professor Umar Javed,
Professor Ajaz, Professor Ricard, and all the dignitaries. Professor Shaukat Jilani, I don't count as an outsider. Professor Shaukat.
Nobody is outside, you're outside.
So even I could count Professor Shaukat as my teacher because he was my immediate senior. So teaching.
No, I wasn't your Indian senior, I was 2 years ahead of you.
Yes, sir. Yes.
Your sister was my classmate, not different.
So, as although I missed most of the opening session, what I realized is that surgery has come along. The kind of clean dissections I see being done laparoscopy are unbelievable. I have watched some of the surgery, open surgery, and I know what a scene it is. I think as if these videos have been edited by some,
Yes, of course, they were edited.
to perfection. Such clean surgery being performed, and I'm imagining a situation where even now laparoscopic surgery will be super specialized, as Professor Ajaz suggested. That there might be some people who will be focusing on upper GI, some will be focusing on lower GI, some will be focusing on hepatobiliary, and some may be focusing on pancreas. And I am glad that there is a collective collaboration between the newer medical colleges and our medical college. And I would hope that this collaboration, this collaborative separation will continue. And without taking much time between you and lunch, like thank all the organizers for having organized such a nice team.
Thank you so much, sir, for the inspiring words. Now, I would like to request Professor Iqbal sir to please come on and felicitate Professor Invasive.
For coming here, it is an event for us. Yes.
Now, I would like to request Tanvi sir to kindly felicitate HOD sir, Iqbal sir, organizing chairman.
ठीक है वापस करा
Professor Mushtaq Chandni, organizing secretary. Professor Shaukat Zargar, former director schemes. Professor Umar Javed Shah, former director schemes.
I must say here that Professor Umar Javed pioneered into the field of GI surgery, and the kind of expertise he developed in pancreas is unbelievable.
He is helping us almost every day now. He's a part of the department now.
You see, it's got to go back to the school. I read a paper before retirement from Annals Surgery. I wish I could share with you all, those of people who are just about to retire, how that he's the president of the how he has described post-retirement, pre-retirement. So one of the factors was going back to the school. And that's very important. You just take another person. And you don't need name and fame or any money or anything. What you want to see the next generation taking yourself, that's not such out of And in our religion, it is clear. Once you learn, teach. And that's what we allow.
We are thankful to him, we are thankful to the HOD who is coordinating everything, and the patients are getting there. Thank you.
Professor Shaukat Jilani, former principal, GMC Srinagar. Professor Ejaz Malik, HOD, GMC Srinagar Professor Ejaz Malik, HOD, General Surgery Schemes.
I would like to add one point. It's really appreciated for both institutions that we have started utilizing fellowships. This has really given an boost over the new and fellows are to be trained more and more work is to be done, as well as publishing.
Professor Ejaz Rathar, HOD, Department of General Surgery Schemes. Dr. Hakeem Bakar, HOD. Now I request Iqbal sir and Mushtaq Chalku sir to come onto the dais and felicitate our speakers.
Chalku sir,
Dr. Irfan Naziri. Dr. Asif Mehraj. Dr. Rifat Ara.
Rifat did wonderfully well. He just joined us 2 years back and now he's into pancreas.
Professor Abdul Rashid Ganem.
Rashid is doing a wonderful job along with Dr. Shakib in thyroid and carotids. Okay, as well as
Thank you, Iqbal sir.
We'd like to felicitate the sponsors for this event, the Cadila Pharmaceutical. May I request the representative from the Cadila
Now to conclude the session, I would like to request Dr. Hanif to take over and say a few words.
Honorable Principal Professor Tanvir Masood sir, respected Head Postgraduate Department of Surgery Professor Iqbal sir, our most valued invited guests, Professor Shaukat Jilani sir, Professor Shaukat Zargil sir, Professor Umar Javed sir, Professor Ejaz sir, Professor Ejaz Malik and Rathar sir, Professor Dr. Hakeem Bakar sir, respected senior faculty, Professor Nasir Awan sir, Professor Shakil Miel sir, Professor M.R. Adri sir, Professor Mushtaq Ahmed Chalku sir, Professor Abdul Rashid Benign sir, and all junior faculty, registrars and students. It's my privilege to have been asked to propose a vote of thanks on this occasion.
asked or forced.
Asked. I, on behalf of Department of Surgery, extend a very heartfelt gratitude to all the speakers for gracing your work, your findings and opinions today. I must mention my deep sense of appreciation for Dr. Umar sir for sharing with us some of the best management practices and protocols. take this opportunity to extend our most sincere thanks to all our guest invitees and to the Cadillum of Pharmaceuticals. I at the end.
I'll interrupt you just to complete the session.
Yes.
For two important people who made the show, and there's all that. And in interest in John to this.
Can we have Professor Nasiraman, Professor Atri and Professor Shakil there? Just for a minute. Because you always stay in the background. You always No, you are going to give. Always be the giver.
So,
Except for
Dr. Regan, for a moment by all professors, please. She added Jawahar to this. Madam, please.
Madam will give us the last one.
I at the end express my gratitude to the organizing chairman, Madam Graduate Surgery, Professor Iqbal, and organizing secretary, Professor Mushtaqamat Chalku, for their guidance and support. Once again, I want to state that we all are most grateful to all the speakers on this stage. I thank you very much this evening. It's a very great pleasure. Thank you very much again. I would like to announce for the late lunch, registrars and PG students will stay here in this room.
इकबाल सर का